Proper application of physical restraints is primary when you're dealing with someone who is potentially combative. What we're going to show you in this video is how to properly put on those restraints with patient care and safety of responders in mind. Okay, Todd Christensen, we're back with you again for the Crisis Intervention System in Michigan, where we've got paramedic Carson, and we're going to talk about applying those soft restraints to the potentially combative patient. Katie.
All right. So when we apply soft restraints to a patient, generally it is in situations where somebody could be either have the high potential to be violent, have already shown that they either are having violent tendencies, or are doing something to either harm themselves or put us in danger. So why we do this, we want to make sure that we are explaining to the patient everything we're doing, even if they're fighting us, struggling with us. Always communicate with your patient because this is not a very pleasant experience for this patient. So keep them as calm as possible. Typically when we go to restrain somebody, we want to gain control of an upper limb and a lower limb, and typically we go for the opposite. And that's to help prevent the patient from either being able to sit straight up and have both arms, kick with both legs, and then being able to roll or slide off the stretcher.
So we're talking opposites. We're talking like this arm, this leg,
Yes.
and if Rob was a super potentially violent patient, this would be a 4 or a 5 person operation, not just 2 of us.
Absolutely. Typically, it's pretty rare that we do it with just a 2-person situation. It's typically only like in emergencies where we stop on the side of the road because something has changed or somebody has become violent and we don't have help with us.
Great.
So really, in the end, this is about patient safety and provider safety, and to do this with the least amount of force as possible.
Sounds good. So what we want to show you the proper application of soft restraints.
All right. So these are going to be our typical restraints that are on most ambulances. So our blue restraints are for the arms and red restraints are for the legs. If you can't remember in the moment, you can just look at which one is larger. The red is larger, so it will go on the leg. So let you hold on to these ones.
Okay.
So when we do this, typically we'll take one arm, choose one arm, and have one arm up, just like this. So I would get a hold of Rob's arm here, have my restraint open. When we do this, soft side goes to the patient, so this is the padded side. So we're going to gain control of the arm. Your restraint, you want it to go not on the hand, not up here, but kind of on the smallest portion of the wrist. So soft side down to the patient, Velcro. Make sure you can get two fingers in to ensure that you are not cutting off circulation. Apply the third strap over top. So now we have control of this arm. So even if Rob tries to pull, I have something to have leverage on. So now when we go up top to restrain to the top of the stretcher, things you want to be careful of, don't overflex somebody's arm. So if Rob's arm were to stop up here and he didn't have the flexibility, don't force it, just try the other arm. Some people just have previous injuries, things like that. So never force somebody's limb past the point of their range of motion. So as we apply these restraints here at the top, the way that these stretchers are built, typically you cannot restrain this top arm to the frame of the stretcher without hyperextending somebody. So what we do is come to this movable part of the frame. So as we do this, you want to make sure that we're not looping the strap around that red handle there, or else he's going to be able to sit up, lay down, things like that with the stretcher. It'll move on us.
Now that's an important part.
Yes.
Anything that's red on the stretcher is movable, and that's not where you want to apply a soft restraint.
Correct.
Okay.
So avoid all the red things on, that is something that is unique to these Stryker stretchers, but typically anything red will move. So as we apply black to black, and you can give a patient as much extra leverage as they want or as you want. You can cinch this down even further to make it tighter, all dependent on how the patient's doing for you. So this one goes up top. So now Rob has some movement. You can kind of move around a little bit, not feel so constricted, but you still have control.
That arm's locked in.
Yep.
Opposites,
Yes.
right down here. Okay, we've strapped down one arm. Remember opposites. Now we're going to strap down the lower extremity.
So with the lower extremity, same concept as the upper as far as placement goes. So you want to go on the thinnest part of the ankle here. So again, it's upside down to the patient. Try to avoid placing it over clothing, things like that. Socks are okay, but that just helps avoid any constriction to them. So as you apply this, check 2 fingers in. You have your top strap that goes over. So now I have control of this limb. Yep. So we come down, and this gets placed on a non-movable part of the stretcher. So typically this black frame here. So again, black to black. And these ones can be as tight as you want. It all depends on patient mobility. And then that top strap goes over. So now we have our opposite limbs secured, and now we can move on to opposites on the other side.
Upper arm. Let's see if I remember how to do this. Okay. So we're strapping down opposites. Soft part to the wrist. And the skinny part of the wrist.
Yep.
Just like where you would apply handcuffs if you were a police officer. Lock that one down. And then I do black to black. Oh wait, 2 fingers.
Yep, there we go.
2 finger tightness. Circulation. Solid part of the frame. Black to black. Just like that. We've locked in the black strap. Recheck circulation. And we're back to opposite extremity. Okay.
So again, soft part down to the patient. Try to avoid putting this over clothing. That helps also prevent movement of the patient. So soft side down to the patient. And then this top restraint goes here. And so over here, get a better look at where we're securing this to the stretcher. Comes down to this black frame here. So as we go, black side to black side. This is here. This comes up and folds right over. Don't cinch this down so tight that you constrict your IV pool, things like that. They can pop it up, and then if you need to use it, you don't want it to be stuck with a restraint.
So now that we have restraints on, we need to do a little recheck.
Yes.
What do we need to recheck?
So we go back through, now that we've gotten everything on, we want to recheck pulses in both wrists. Make sure that you still have good strong pulses in the wrist. So we'll come up, check a radial pulse. If you don't have pulses, the restraints either need to be loosened or readjusted. Typically, sometimes patients will pull on them and cause them to constrict on themselves. There's only so much you can do about that, but you do need to reassess about every 5 to 10 minutes, depending on what's going on.
Radial pulse, capillary refill.
Yep, so you want your capillary refill to be 2 seconds or less. And then down here at the feet, typically shoes will come off and you'll check pulses on the tops of the feet, same cap refill. Basically, the more the patient struggles, the sooner you need to be checking this, and the more frequently you need to be checking this.
And again, if this was a violent patient, this would be a 4 to 5 person operation.
Absolutely.
So once they're strapped down, now we're ready to apply cot straps.
Yes.
And transport.
Yep, so it's always important to remember that once somebody is restrained, that's not ready for transport yet. So always have to put seatbelts and the appropriate cot restraint system. So what we'll do is shoulder straps first.
And should I go over the arm or under the arm?
You want to
that's
go under
secured?
the arm, and that's just so you're closer to the patient.
Makes sense.
To prevent, it's kind of like having a loose seatbelt. You don't want a loose seatbelt if you're in a car. So this will be the waist straps are going to be the ones that come over here. So these will come right through here, secure. You want it tight, but you still want to be able to get some movement in there. You don't want to be constricting on the patient. And then we have chest strap That's still under the arm. So basically you just don't want to go over because it does not secure somebody.
Under the arm.
Yeah, under the arm. And then that'll be the same on this side. And here. Biggest thing about is if you do have chest straps, if your stretcher has chest straps, this is not to be used as a restraint tool for the patient. These are only for safety of transportation. So if patients are trying to sit up, things like that, absolutely, we do not want to be tightening this down, constricting the chest, not having a lot of movement. This is only for the safety of transport here.
And a big key point about this chest strap, especially with your excited delirium patients, is sudden in custody death syndrome. This can't be tight. The patient has to be able to breathe.
Correct. And so once the patient is secured and everybody's on the same page, we can move to the ambulance. And typically in these situations, we'll take somebody to ride along with us in case we run into any issues. Again, the sudden death, which people are at high risk of when they are in restraints.
Any other protocol issues we need to be concerned about with soft restraints?
Protocol-wise, we always need to be reassessing our patients. The goal is to try to verbally de-escalate somebody before going hands-on. So that is in the protocols to at least try to talk somebody down before we go hands-on. And talk to your patient through the entire scenario. Vitals need to be reassessed, so heart rate, blood pressure, oxygen level, things like that. And just because somebody is in restraints does not mean that we aren't still treating them medically. So if they need medications, things like that, we need to still be doing that and be diligent providers for our patients.
You brought up a good point, de-escalation. So restraints is last resort.
Yes.
We should have done everything possible to calm our patient down and de-escalate them to the point of compliance rather than have to restrain them. But we know if someone's beyond control, we've got to restrain them.
So when we do restrain, we need to act quickly, and that's for the safety of the patient as well as us. We don't want to give them the chance to fight, become combative. So once the decision is made, we all need to be together on the same page and we all need to act as a team to get this done. But this really should be the last resort. So even if that means you're on scene for an hour talking somebody down, that means you're not putting them in restraints. That is the better outcome for your patient and for yourself.
That's great. And you know, that's exactly why we want to train as a system in the Michigan Crisis Intervention System, so we all know what we're supposed to be doing.